All right. Thanks, Greg, for masterclass in lung transplantation. So I was really inspired to do my MA with Greg when I did my ICU rotation in 2022, and I was impressed at the the sickest patients that I've ever really seen in my life. They have ICDs, they've got multiple lines, they've got VA ECMO, so large bore needles in the arteries. They're ventilated, they often need dialysis post-transplant. And yet, if they survive, it is completely transformative for that person. And what struck me was how infections was sort of such a real vulnerability to what is otherwise a life-changing therapy. Greg and I did a study on specifically on tuberculosis and fungal infections. And the reason we did that is that there's only two lung transplant centers on the African continent, and Greg has spoken about this. And we have several challenges in Cape Town that don't really exist in the first world or in other settings. For example, Khayelitsha has one of the highest incidences of tuberculosis in the entire world, and we know that's likely true for the rest of the Western Cape. We also have a burden of endemic fungi, dimorphic yeast and molds, which is not really well characterized in our setting. So I set out to characterize or at least describe these infections in our cohort. So for the sake of the talk today, I'm going to go quickly through just the study methods, an overview of the cohort data, the spectrum of TB, and by spectrum I mean all the manifestations of tuberculosis that we identified in this cohort, what the fungal microbiology was, and then I'm going to throw some rapid fire cases at the ID audience to see what people would do in different scenarios. I have more data at the end if there's time or any questions, but specifically on bloodstream infections, donor microbiology, and CMV. I'll leave it for the main if we can get there. So it's a very simple study. I was told by numerous people this is wisest for an MMed. And it's retrospective. We included patients from the start of the program in 2018 until December 2024, and all results and outcomes were blinded thereafter for pragmatic reasons. We captured all microbiology and histology results from NHLS, and obviously had the clinical data from a central database. I deduplicated cultures for bowel and blood and other sources within 7 days. I don't mention it yet, but infection is also inferred from histological results with compelling indication. And the study is a focus on the TB and the fungal results. So the limitations of the study is essentially, I just want to get this out the way, is that the sample size doesn't really match, as you can imagine, with what Greg is showing. They have centers in America that will do this in a few months with the N of 44. It's also very difficult to attribute cause of death retrospectively with a small number, especially when it's so multifactorial of allocating was this infection or rejection or an ICU complication post hoc. There's also short follow-up for many patients, so there's not necessarily a full amount of time that you would adequately be able to get a sense of endemic infections or the community-acquired period from 6 months onwards to a year and even beyond. Retrospectively, also ascertaining the pollinization versus infection is difficult. I think for ID physicians, that's difficult. With the patient in front of you, it's even harder with just a piece of paper. And then for the sake of simplicity, the infection density and infection rate per patient was not calculated. So this is just a descriptive study. So Greg has really spoken about the prophylaxis protocol. And I think what I really would highlight from here is just the INH is obviously of interest. And just to reiterate, what I didn't know as someone coming from a general medicine background is the amphotericin B nebulization immediately post lung transplantation. And there is really a stratification of who gets mold prophylaxis, usually Aspergillus as well, mold prophylaxis. So this is our cohort. It's total number N. The median age of transplantation is 48. As we mentioned, there's two centers in South Africa. One is purely private, so medical aid exclusive, whereas medical aid was actually patients on medical aid was actually the minority in the study, which is just of interest. And the indications that we had for lung transplantation still predominate in terms of cystic. We still have predominantly cystic fibrosis, COPD, sarcoidosis, and as a sort of major indications, which seems to match the first world indications. What we did have, which is maybe a bit unique, is that prior TB was noted in the history of 8 patients. We included 2 patients living with HIV, and there are still to this day only small cohorts with data in lung transplantation and HIV. So the median time to death of non-survivors, and if you look at the Kaplan-Meier curve, it's like if you get through the initial ICU period of intense infection incidents and surgical complications, the likelihood of doing well is much higher. And South Africa has we have a 1 year survival rate of 67.5, and CMV positivity, seropositivity, that's IgG of 86.7%. So this is just a table summarizing the infections, and it's a lot of text, I understand, but I want to get to a figure which coming up. So just to lay the scene, there are cases of, we have a lot of bloodstream infections. I have the microbiological data, which at the end, if we get to, or anyone has any questions, I can show it. We identified Aspergillus not infrequently on 11 occasions. 6 patients had COVID-19. Candidemia occurred in 4 cases. We have 1 case of tuberculosis, nocardiosis in 1 case, CMV pneumonitis based on histology in 1 case, and C. diff. You can look, it's within a median of 20 days, so it's really a sort of an in-hospital complication or hospital-acquired infection. But this is really the crux of the study. And what I wanted to point out or try and summarize just as a narrative is I try to find a way in which I could encapsulate all the sort of experience that has been accumulated in Grubisky's lung transplant cohort. So I came up with a plot that predominantly focuses on visualizing nucleic acid amplification tests. We know there's like Expert Ultra and Gene Expert and Gene Expert Ultra. So this is just an umbrella term for all of these tests. And I'll explain, I'll go one by one from the top so we can talk about what has transpired. So this one patient that was treated about 2 years before for Gene Expert positive tuberculosis, had a lung transplant and subsequently had no evidence of TB on IPT, INH. There's one patient that had TB prior, and at the time of explant was noted to have active tuberculosis. So,
yeah, we do the radiology every 6 months, and he transplanted at the end of that period. And we were called by the histology lab to say that when they've done their sections of the explanted lung, they found a small cavity. So we did reactivation and transplant. Kind of treated his TB by cutting both his lungs out. But obviously, he should have to receive treatment of that.
So my next study is bilateral lung transplantation for treatment of TB. So there's one case of explant TB is gene expert positive, and the other one is, as Greg mentioned, was on a histological basis. And I think it's important to note that both cases were treated with REFA4, anti-tubercular therapy.
We switched to regimen for rifabutin because there's much less activity in VA4. So otherwise, I think it's massive dose therapy is very expensive.
But they were treated for. I don't think the take a chance method was. Yeah. So unfortunately, there was one case of donor-derived tuberculosis, and it happened to occur in 1 of 2 HIV positive patients, which was terrible timing, but basically the donor lungs were screened, and despite this, were nucleic acid amplification positive and culture positive for rifampicin sensitive tuberculosis. And
They were treated without incident.
yeah. And then, in summarizing this data, I came across a pattern which has now occurred in a significant amount of patients, so about it's like 8%, of patients with transient nucleic acid amplification positivity. So when going through the database, I need to mention that these patients have an intensity of surveillance that other cohorts at risk of tuberculosis just do not have. I guess the equivalent would be if you have someone at risk of UTIs or doing the urine MCNS every week. So you really do pick up quite early what is colonizing and what is occurring. So I think that's quite a unique strength of this cohort, is that we have a high burden tuberculosis setting. We had a very high intensity of surveillance. And in 5 cases, we had patients that round about 100 days post-transplantation, no prior evidence of tuberculosis, and no evidence of active disease. Have a gene expert that flags positive. If you look on SPV, it usually says low positive or trace, so the amount of DNA is very small. The samples, none of these samples managed to grow anything. And the second thing is any sort of subsequent follow-up of this, of these patients reverted to a negative gene expert. And the perception is, although we need to study this further, is that there's no features of active disease or indication downstream that maybe we should have treated this. And I want to just talk a little bit about transient positivity or TNP. So the definition that I think I was thinking about, we can discuss this, is a positive gene expert, is trace of rifampicin unsuccessful. There's no evidence of TB in donor lungs. There's no clinical evidence of disease. Culture negative, and follow-up bowel samples are negative from culture and gene expert. The median time to event is 91 days. So this seems to be something that occurs relatively early on post-transplantation. This was a very interesting phenomenon. I don't think it's described anywhere else in the world, for the reason of you never have an intense surveillance of a good specimen in a high burden setting. And the possible causes that I considered is, number one, are these technical factors? For example, is this just a false positive? And I know the microbiologists probably give far more insight into that. Is this donor lung sort of reactivation of TB that is actually treated with the INH? Is this aborted transient infection, especially at 100 days out? Patients that do well will usually be back in the community. And it's not unexpected. It's been said that the air is tuberculous in Cape Town. And so it's not unexpected that patients will be exposed to TB. And then there are, so I just wonder if there's sort of other ideas as to what causes this phenomenon. Does anyone have any suggestions? Maybe we'll leave that to the end. So I'll bring it up again in the discussion. And the next thing I wanted to focus on was the microbiology and fungi in non-transplant recipients. It's for 2 reasons. Number one is that fungal epidemiology is one thing that can differ by geography. We obviously have a lot of data on Enterobacterales and CREs, which you would really expect in any ICU anywhere around the world at this day and age. But fungal infections tend to differ by geography and antimicrobial and antifungal use. So in our cohort, there were a small number of infections, and I'll get to the caveat soon, but there was one case. So all donor lungs are screened. There's a swab that's sent off, and there's also a graft that's sent off. And one patient had Candida albicans identified in the donor, and subsequently also identified in the recipient. And why this is significant is, as Greg mentioned, is a sort of general rule in infectious diseases, Candida albicans in the lung is not a significant organism. But in transplant, the rules kind of change because of the entity of bronchial anastomosis dehiscence. And then in terms of blood, there's a smattering of yeasts, but majority of bloodstream infections were bacterial. Fungal infections occurred. One was a trachosporin species, and then there were 3 candida infections, and only one was an albicans, so there were 2 non-albicans, parasilosis and tropicalis. And although couldn't attribute death in general, when I was in ICU, one of the cases was actually both of these cases were present in ICU when I did the rotation. So I can say that I think this played a significant role in the patient ultimately demising. And then bronchial alveolar lavage organisms are more difficult to assign infection versus colonization. And there's a range of fungi that are identified. And I think the take-home message is that you do often see Candida. In most settings, it's not significant. But if you do a bronchoscopy and you see dehiscence or concern for infections, then you would treat it. We also very surprisingly had Penicillium and Telleromyces come up. And then when it comes to Aspergillus, which Greg has really mentioned, the challenge of mold infections post-transplant, there's quite a good representation of Terrius, Niger, and Flavus as opposed to Fumigatus, which might have implications for prophylaxis, which I'll get to. So in terms of the timing of when fungal infections occurred, it's really difficult. I wasn't bold enough to do any statistics on the end that I had here, but the cases of Aspergillus sort of occur throughout the transplant period. Candidemia in this setting, at least, 3 cases occurred early, 1 case occurred very late. Telleromyces and Penicillium sort of firmly occurred in the community-acquired or risk phase. And Trichosporin I can chat about, but who knows what to do with that. So the discussion on my microbiology, my fungi results, is that actually, from what we see, non-albicans Candida and non-Fumigatus Aspergillus were predominant. Infections occur across all time points. And I just wanted to flag something that was a learning point for me in writing up this data, is that we use routine amphotericin B nebulization, and Aspergillus terreus, microbiologists might be able to comment, is one of the organisms that can be resistant to amphotericin B. And it's just interesting that it's come up. And then big learning points, Candida albicans on bowel, it can be significant. It's not always to be ignored. I found, and then the other thing is, I had assumed this patient must have traveled to Telleromyces, so it might be if the donor has a history of travel, which is hard to get. But in actual fact, data of ecological studies in the Western Cape shows that Telleromyces is a natural host in the Fynbos ecosystem. So watch the space in the future. And we also know that the diversity of Aspergillus species is not fully mapped in South Africa. So my conclusions from the study is that donor and explant TB is very difficult to avoid in this setting, but is manageable. And it's really important to say that no cases of post-transplant TB occurred, despite these, what I call transient nucleic acid positivity. And this is likely due to how maybe we're just seeing in real time how isoniazid works. Maybe it just sterilizes your lungs very soon after an infection seeds, and you get a little bit of the DNA that's detectable, but the bacillus doesn't grow, and no one else has seen this because they're not surveilling for it. And then the next conclusion we had, which is still an open question, is given the frequency or given the amount of Aspergillus that is identified and dimorphic yeast later on, is there any benefit to posaconazole or isobuconazole in our setting? And although in the first world this is a much easier question, but in our setting it's the cost restriction is probably the main problem. I have some quick cases if anyone has time, or should we call it here.
Maybe one at most because
Okay.
5 minutes.
Okay, so I'll take you, so going through a cohort of lung transplant cases is really sort of eye-opening for anyone that wants to do infectious diseases. So I'll take you through a journey of rabbit holes that I went down. And if anyone has any comments or you want to tell me what you have done, or tell Greg what you have done, then yeah. So the one is post-lung transplant, alkylagenase trichatus, sternal osteomyelitis. The wound is broken down. The sternum is biopsied by the cardiothoracic surgeons, and a bacteria called alkylagenase grows.
Oh my God.
Call micro. Okay.
It's a multiple cell cancer.
Yeah, it's on a sterile, so it's on bone. Yeah.
One.
Yeah.
They didn't take 5 specimens.
No, they should.
Yeah.
There's a lot of this one.
So persistent positive rhinovirus on the bowel and nasopharyngeal swab from day 1 to day 487. 9 samples.
Stop testing.
Stop there. Spore in the species.
Yeah.
So is a described pathogen. Very interesting. There was a rotatorula that was cultured in Heidelberg in an infant, and I had to read up on fantastic yeast, so where to find them. So that was an interesting one. So Cryptobacterium endogenous pneumonia and BK virus hemorrhagic cystitis at the same time. Happens. Bad luck. Telleromyces identified on the bell. Real donor.
Well, my question is it a telleromyces?
99.7.
Yeah, so we go
99.7.
bad fungal PCR.
Yeah, 99.7% likelihood.
Yeah, but they have a very close relationship with penicillium.
Mm.
They were the environmental.
So it's interesting that they do this for fangboss ecosystems and like the spores on around in fangboss. Because the donor lung has cultured Merozyma gillamondia. It's actually a character. So
Let's just check.
yeah, I was, and
Sorry, which candy?
And the last one is CMV, so non-resolving ulcer, biopsy and CMV positive. And the Brevandemonas diminuta of tracheal aspirate was done. So there's a real smattering of cases that really made me dig deep into various textbooks, and I think a lot to learn from lung transplantation and solid organ infection, even in like especially at critical care. And so I'm gonna, for the sake of time, I'm gonna ignore that and just acknowledge. So we did put a draft of a paper, we submitted it, and this is the author team that were involved. Thank you.